major mediators in things called hereditary angioedema. So again, differential diagnosis, if you have histaminergic, quick in onset, quick to resolve, often associated with urticaria. Non-histaminergic, more painful, stinging, dull ache, resolves over hours to days. Onset over hours to days, and is not associated with urticaria and does not respond with epinephrine, antihistamines, or corticosteroids. Going back to Harkless's chart here, if we just separate down the middle here, and you're talking about non-histaminergic angioedema, if you do complement testing, complement C4s, C1 inhibitor level, C1 inhibitor level function, and you find that it's normal, then you look to the family history. And I mean, quite honestly, your first question is, before you do any of this, is to ask, are you taking an ACE inhibitor? Okay, if they are, well, stop it, okay? But even then, what you're going to find is that some of our primary care physicians, they're very smart people, and they'll know that the angioedema is associated with ACE inhibitors, and they'll stop it and they'll immediately put them on an angiotensin receptor blocker or an ARB. And then a week or two later, patient's got the angioedema again, okay? Now, it must be an allergic reaction to ARB. Wrong. It still can be the ACE inhibitor. In fact, patients who have ACE inhibitor angioedema may have it as long as 6 months after they've stopped the ACE inhibitor. Okay, so keep that in the back of your mind. As far as the rest of this here goes, all right, do your molecular genetic testing, and if, as far as the family history, I don't know about y'all, but all the patients that I've seen with hereditary angioedema with normal C1 inhibitor have no family history. Okay, they're all de novo. So that's kind of unique, but you can get some of this genetic testing through INVITAE, I-N-V-I-T-A-E. National Jewish does it, and I know that Mayo's does it also. But they only do it for about 4 of the antigens, including the SIR-Ping analysis. And the SIR-Ping analysis is being asked by some of your insurers in order to get pre-qualifications for certain medications like Takhzyro and other C1 inhibitor medications. If you do have a C1 inhibitor deficiency, it's nice to have that family history. It's an autosomal dominant. So there's going to be a 25% chance that a child is going to have it within the family, and overall a 75% history of angioedema in the family. And then, so if they have a low C1 inhibitor level, then you have C1 inhibitor type 1 angioedema, and if it's dysfunctional, it's C1 inhibitor type 2, all right? And otherwise, if there's no family history and you have a deficiency, then check a C1q, all right? Because the C1 inhibitor deficiencies will not have a depressed C1q to begin with, okay? That's due to usually some type of malignancy or can be associated with lupus, SLE, all right? Again, going to the bradykinin-mediated type of angioedemas, went over those here, including the ACE inhibitor. But when you're looking at differential angioedema due to contact dermatitis, the classic example is poison ivy dermatitis, okay? People come in swollen eyes after rollicking in the woods. Think of that, okay? And then Gleich syndrome is the eosinophil, where the patient will have a sudden increase in peripheral eosinophilia associated with an increase in 10% of their body weight. So they'll have a diffuse swelling all over their body, and then a diuresis like that, and it goes away, as does the peripheral eosinophilia. And then hypereosinophilic syndrome is another one. So when you're looking at patients who have bradykinin-mediated angioedema, i.e. Hereditary angioedema, versus those that are histaminergic, those who have bradykinin-mediated angioedema are a lot more capable of predicting when they're going to have an attack. I mean, these people are so frightened of these attacks, and you'll see why in a minute, that they can pick up on it, and they know when they're going to have an attack, because their prodromal symptoms usually start off with GI symptoms as nausea, but they know they're going to be vomiting and having extreme abdominal pain very quickly thereafter, okay? Whereas histaminergic, maybe you might get some people that can detect it with the tingling in their lips as well as elsewhere. So this is an example of hereditary angioedema. As you can see, this gentleman's belly has just been filled with gas due to the fact that his bowels are all swollen. And you can imagine the pain that that gentleman is going through. When you do a contrasted CT scan, you're going to see bowel wall edema and obstruction. Again, urticaria is not associated with this. It's not autosomal dominant, and attacks can last between 2 and 5 days. The majority of these people who die from this die of asphyxiation because it involves the upper airway, okay? And very rarely can they have a third spacing of fluid, usually during delivery for a pregnancy lady. And what you want to do is you want to avoid the ACE inhibitors and as well as estrogens. So this is where all the business is here. It's in the kallikrein-kinin contact system, but you can see how the coagulation system produces the Hageman factor 12 gets activated, and then the complement system also interrelates, and they often feed back on one another. This is the mechanism of the angioedema for all of those who want to know and for those who don't. You have the receptor for the complement head that is activated along with activated factor 12A, high molecular kininogen, and prekallikrein splits the HMK into bradykinin. Okay, and this is all at the surface of the endothelial cell. So as a result of the bradykinin, it stimulates the bradykinin 2 receptor, and that allows for production of nitric oxide between the cells. It allows them to split, and that promotes loss of intravascular fluids into the interstitium, and there you have your angioedema. So again, this is a quick one. You test for all of these in patients who have chronic angioedema. And if they're all decreased, then it's most likely HAE type 1. If there's no family history, and especially if you're expecting something unusual as to be an acquired angioedema, then just check a C1Q. If the C4 and C1 inhibitor function are decreased, then you have type 2 angioedema. And if they're all normal, and if you get lucky to have a family history, check the genetics by Invitae. If there's no family history, then it's other mediated type of reactions. This is one of the acquired forms, and it's mostly monoclonal gammopathies as well as leukemias, lymphomas, B-cell malignancies. And again, the C1Q is going to be reduced. Sometimes they may have this on the surface of the B cells. And of course, with patients with systemic lupus erythematosus, they have activation of the collagen-like fragment of the C1Q, which is the first component in the complement cascade that induces them to have that acquired angioedema. All right, so we've talked a little bit about the inherited forms. Now I want to spend time on the normal C1 inhibitors, okay? And these are patients who have bradykinin as a mediator. Most of them are women. They have mostly oropharyngeal and abdominal attacks. And the diagnosis is basically made by the response to the C1 inhibitor therapies. These patients may have a genetic identification based upon family history. They do not respond with glucocorticoids, epinephrine, or antihistamines. Again, this is another picture regarding where the internal workings of this system occur, and you have your factor 12, you have your kininogen, prekallikrein gets activated in this high molecular kininogen to kallikrein, and then bradykinin is produced that then provokes the angioedema. A couple of other types of abnormalities genetically are the angiopoietin genetic abnormality and a myofibrilin, and those don't seem to have any relationship to the kallikrein contact system, so they may not respond with some of the medications that we might use that do affect the kallikrein system. I'll tell you what, I've got 3 minutes, and I'm going to jump ahead of all this just to say that these are explanations of the genetics associated with the mutations that occur in factor 12, plasminogen gene, the angiopoietin gene, the kininogen gene, the myofibrilin, the heparin sulfate, sulfotransferase mutation, which promotes the migration of the high molecular kininogen into the cell. And then that way, if there's an abnormality in that, it reduces its ability to keep it out of the cell and thereby increases the risk for patients to have angioedema. One thing about factor 12 deficiencies in women especially, and this is a reason why the majority of folks with C1 inhibitor, with hereditary angioedema with normal C1 inhibitor are women, is that estrogen has an adverse effect on the development of the angioedema because it reduces the degradation of bradykinin and it binds sex hormones. So you can see here that it increases high molecular kininogen and increases the effect of factor 12. Let's go through here. We'll get some. So this is a summary statement here of the pathophysiology of all the abnormalities that are associated with hereditary angioedema. You can see factor 12, plasminogen, kininogen, the sulfur transferase here, and then that's everything on this side, which would be kallikrein mediated, and then the myofibrilin and angiopoietin, which is not kallikrein mediated. All right, therapies, we have FDA approved therapies, ecallantide, icatibant for immediate treatment of attacks, as well as the C1 inhibitors. And again, this affects the kallikrein system, where if you provide more C1 inhibitor, then it inhibits the activation of the kallikrein, as well as other feedback mechanisms that promote the angioedema in these folks. And then icatibant directly blocks the bradykinin receptor and prevents angioedema for it. And ecallantide or Kalbitor blocks at the kallikrein itself, okay? This is C1 inhibitor infusions that you can get medium onset of relief within the hour of its use. Ecallantide, usually within 4 hours, the majority of people are going to have relief. And icatibant's much faster, usually an hour and a half to 2 hours. Other therapies are prophylactic, and you can see that you have danazol and plasma-derived C1 inhibitor. Danazol is old school, not recommended now. Lanadelumab is a kallikrein inhibitor, as well as berotralstat. The problem with androgens is the development of virilization, hepatotoxicity, weight gain. These are prophylactic agents, looking at the plasma derived, and this is indicated down to the age of children, is it has to be prophylactically administered, usually twice a week. And then ledanomab just got a recent age indication to much younger ages for children. Usually 300 milligrams every 2 weeks to start, and then some are able to gravitate out to every 4 weeks. And then berotrolstat or Orladeyo, this is information regarding reduction in the monthly attack rate seen with those products. And again, this works for not only your patients who have hereditary angioedema types 1 and 2, but also your HAE with normal C1 inhibitors, okay? So that's one of the things to think about, is if they don't respond with this, that's not their diagnosis. And then we're going to talk a little bit about prophylaxis with a couple of different off-label medications. Tranexamic acid, this is a small study done with those who had hereditary with C1 esterase deficiency. It didn't work very well, but those who had normal C1 inhibitor, and again, this is a study of about 6 patients, it seemed to fare better, as well as with idiopathic angioedema. The problem with tranexamic acid is it's fibrinogenic. And this is progestin, which works very well for ladies, okay, as far as reducing the attacks, either by low progestin only pills or by antigonadotropic progestin agents work in both the normal C1 inhibitor angioedema as well as idiopathic angioedema, okay? So I think I'm going to stop there, and there are a bunch of new agents that are on the market, but so much I can talk about in about 15 minutes, okay?
Thank you so much. I know that's a large topic for